Hi everyone. I want to talk about acute pancreatitis. Acute pancreatitis is an acute inflammation of the pancreas. Let's go. Here we can have what we call hereditary pancreatitis, and if that is the case, we might be dealing with either autosomal dominant protease 1 inheritance. When inheritance is autosomal dominant, it means once that gene is present, the affected individual will manifest it phenotypically. But in case of autosomal recessive cystic fibrosis transmembrane conductance regulator, there is that need for both parents to be carriers before they can produce homozygous alleles that will manifest phenotypically in the offspring. To get a clearer picture of this autosomal recessive CFTR gene, you can check my presentation on cystic fibrosis again, where I have gone into details about this inheritance. And unfortunately, the affected people with cystic fibrosis will always have sticky and thick mucus production, which will affect the pancreatic gland a lot. And now we are talking about pancreatitis just now, and reference is made today. So there's no way we can shy away from the fact that cystic fibrosis is a very important genetic disorder, and every affected people will need our help. So as we are dealing with pancreatitis here, we are making reference to that again. And inheritance could be complex genetics as well. Okay, alcohol. So we've seen autosomal dominant protease 1, we've seen cystic fibrosis, inheritance, we've seen complex genetics, and now alcohol. We are going to talk at length about alcohol as far as pancreatitis is concerned, but please, if you can, within your power, do everything to reduce alcoholism. Why? The aldehyde is produced when alcohol is consumed, and that will influence cholecystokinin. Cholecystokinin, unfortunately, can activate the zymogens. The zymogens are not expected to be active until they reach the small intestine. But in this case, alcohol will facilitate activation of zymogens while still in the acinar cells. And because they are there and they are now active, they will cause what they call autodigestion of the pancreatic gland itself. So that is the problem with people that are drinking alcohol a lot and they are coming down with pancreatitis. Gallstones are other issues that will cause pancreatitis. It is mostly due to backflow of the pancreatic enzymes because of the obstruction at the ampulla. So the content is not empty into the duodenum, but it now back in the pancreas. The ampulla obvator is where the content is supposed to go through sphincter of Oddi into the duodenum, where the effect of the enzymes will be fed. But when there are gallstones, blocking that pathway, then the content will flow back to the pancreas itself and start digesting it. Hypertriglyceridemia. I cannot overemphasize this. In fact, I have made a separate presentation on hypertriglyceridemia and acute pancreatitis. I think I posted that just a few hours ago. I will advise that you check that out and that would be self-explanatory. Medications. Um, a lot of medications could be culprits here, like sulfonamide, trimethoprim combination, etc., some call Bactrim, aspirin, diuretics, tetracycline, and estrogen could all, lead to situation where we'll come down with acute pancreatitis. After a procedure like endoscopy, retrograde cholangiopancreatography, which could be therapeutic and at the same time as diagnostic, but not everyone who will have this procedure will go scot-free. Some will actually come down with more trouble after the procedure. Your doctors will explain to you before you sign and get it done, because the procedure is meant to diagnose and as well help in treating situations on ground that could be discovered while the procedure will be ongoing. Injury or trauma may lead to scarring, and after that we have what we call stricture. With that, then there won't be flow of the pancreatic enzymes to the ampulla of Vata and to the duodenum. Autoimmune. Autoimmune, like I've said in many of my presentations, that when you find one autoimmune, you should be on the watch out for the rest. So the simple meaning of autoimmune here is that your normal body fighters are now fighting the normal structures. So in this case, the pancreas is being attacked by the body immune system itself. That's why we call it auto. So within the same system, autoimmune condition could also cause acute pancreatitis. Periampullary carcinoma. When there is periampullary carcinoma, I've said the other time, the content from the gallbladder, from the pancreatic duct, and the common bile duct, and everything like that will open up into the duodenum through the opening and closing of sphincter of Oddi through ampulla of Vata. But when there's cancer along that ampullary region, there will be obstruction. And when there is obstruction, the enzymes will flow back into where they have come from, which is the pancreas. And you understand what will follow? Autodigestion. Infections, parasite, fungi, legionella, mumps, cytomegalovirus, hepatitis B, HIV. Let me just pick mumps here. Like most kids will have mumps, and there's possibility of mumps occurritis, mumps parasitis, mumps everywhere. So now we could see that mumps could lead to acute pancreatitis. I think I'm going to make a separate presentation on mumps very soon. When we don't have any cause per se, we've done our investigations, we look for everything, we've taken history, and we can't come down on a particular cause, we call it idiopathic. What is the pathogenesis here of acute pancreatitis? It is largely hypothesized that autodigestion is the main trouble. Like from what I've said in the last few minutes, is all about autodigestion, because the enzymes, the zymogens are supposed to be inactive, and anything that makes them active and they are digesting the tissues, the pancreas itself is the problem here. Whether they already produce an activated zymogen now flowing back, or anything at all that will let the enzymes work on the pancreatic gland will lead to pancreatitis. Oxidative stress and cytokines released by, we have talked about some microbes just a while ago, and so on and so forth. Now, cholecystokinin prematurely. I've said again prematurely because that will happen before reaching the intestine. If cholecystokinin, CCK, activates zymogens in the acinar cells, then we have trouble because the zymogens will be in active form of the digestive enzymes that are not expected to be active until they have reached the intestine. But if for any reason like the presence of acetaldehyde from alcohol consumption will activate cholecystokinin, who will in turn prematurely activate zymogen, then we are in trouble. And the trouble will be acute pancreatitis. Fatty acid, ethyl esters from alcohol will do the same. You see now, from this page alone, we've been talking about alcohol, and alcohol. So alcohol is a key culprit in acute pancreatitis, just like hypertriglyceridemia. And of course, alcohol is not exonerated from even high level of hypertriglycerides also. So it still boils down on the fact that we have to cut the alcohol intake or abstain completely. The clinical features of acute pancreatitis could be mild, in which case there's no organ failure, no systemic complications. Could be moderate if there is transient organ failure that will resolve within 2 days, within 48 hours. But mostly could be severe when there is persistent organ failure that could even involve more than one organ. So in that case, multiple organs will be involved. Later on, when we go over the clinical features in details, we will get a clearer picture. There will be epigastric pain, mostly severe, and it will be radiating to the back because it is not all the parts of the pancreas that is within the peritoneum. The part is retroperitoneal. The localized pain to the right upper chondral region will give a clue that gallstones are involved. There is possibility of nausea and vomiting. Dyspnea, shortness of breath, or respiratory distress syndrome may occur when the diaphragm is inflamed and there is secondary pleural effusion. Then pulmonary edema will be a culprit here as well from acute pancreatitis. There's what we call eagle finger sign. Eagle finger is the name of a doctor in the past. We are remembering him today. What it means is that the pain is relieved by sitting up or bending forward. Sitting up or bending forward. And we'll also find this in pericarditis. So it's not specific to pancreatitis alone, but it's a big clue when that is part of the history that the patient furnishes the doctor with. So eagle finger sign could be pericarditis or acute pancreatitis. There's possibility of fever. Fever, hypotension, the blood pressure will be down, particularly if there is hemorrhagic pancreatitis. There's bleeding internally. Cooling sign, bruising in the periumbilical region within 48 hours, and that predicts the severity of the acute pancreatitis. It's possible you're going to find great turner sign, that is bruising along the flank, and that is an indication that there is retroperitoneal bleeding or pancreatic necrosis going on. So you'll find out on physical examination. Hepatomegaly, because in my uncle that is drinking alcohol, xanthomas in increased lipid. By the time you go over my presentation on pancreatitis and hypertriglyceridemia, you will get a clearer picture of this. Parotid enlargement, I've just mentioned mumps, and I'm making a promise I'm going to make a separate presentation on mumps in the next few days. So we'll get a clearer picture by the time we put all this together. Okay, in conclusion, for the moment, the next presentation on acute pancreatitis will be on investigations, treatment, and complications. The reason why I broke it down that way is so that not to weary you with just one presentation that will take almost 1 hour. So we're going to meet very soon to go over investigations, treatment, and complications in acute pancreatitis. Thank you for watching my videos. Be on the lookout for the next video on this. Thanks.